स्टार्ट हो रहा हो बंद कर दो उसके बाद
Yeah, it's finally the time. It's 10 o'clock, and welcome all. Good morning, friends, seniors, and all my colleagues. Let me welcome you to the first webinar of our ambitious MedTalk series of webinars on behalf of Team IMA Dwarka. Now, this series aims to bring continued medical talks right to your doorsteps through your devices so that you're able to access them wherever you are, whenever you wish to. We also intend to record and distribute this through the YouTube channels, but that would be for later on. So let me first introduce the topic of the day, which is demystifying backache, a case-based approach. And for this, we have two very renowned people whom I think everybody in Dwarka already knows. We have Dr. Neeraj Gupta. He is MBBS DOT, DNB, and FNB Spine. He is Senior Consultant Spine Services in Indian Spinal Injury Center. And we have Dr. Rajnish Kumar. He is an DM Neurology, and he is Principal Director and Unit Head, Max Super Speciality Hospital, Dwarka. Welcome, sir, and it would be a pleasure and an honor to have you elucidate the topic. Now, back pain is one of the most frequent and often frustrating complaints that we encounter in the clinical practice, and it accounts for significant portions of primary care visits, specialist referrals, imaging requests, and even surgical consults. But despite its prevalence, the approach to the back pain remains riddled with uncertainty, variability, and at times overtreatment. Today's session is designed to move beyond the generic algorithms and delve into practical case-based scenarios that reflects the real complex world scenarios, presentations. So we'll be examining the common patterns, atypical features, red flag symptoms that demand a high index of suspicion, and I would request all of the audience to please make use of the chat to send us your questions that you have. If we are on the same patient at that time, we will continue and answer on the same time. And if it is later on, then we'll talk about it at the end of the session. So now throughout this webinar, we'll explore how to integrate clinical reasoning, judicious use of our investigations, and evidence-based management, all the while keeping patient outcomes and system efficiencies in focus. So let us begin our journey today to demystify back pain one patient at a time. So we'll start with the first case. The first case is a 30-year male with injury to lower back while lifting heavy weight, severe low back pain, significant leg pain, and no significant leg pain. Ball and bladder are normal, and neurology is normal. So this is a typical scenario that we find in younger age groups. So usually occurring during gym. So my first question would be to Dr. Neeraj. Sir, can gym or other sports cause these problems?
Uh, Thank you, Dr. Tushar, for this opportunity, and thanks IMA Dwarka for giving me this opportunity for this discussion. So, as we see this first case, patient is a 30-year male who has got injury while lifting heavy weights. So, such injuries usually occur in the gym these days, and we routinely see such patients in our practice. So, what was your exact question, sir?
Can gym or other sports injury
Yes,
actually
definitely.
cause
Yes,
this problem?
yes, sir. These we routinely see these cases because excessive lifting of weight without the core muscles strengthening can cause the rupture of the annulus part of the disc, and this rupture can be there, and it can cause severe back pain. Patient comes with severe lumbar sacral spasm. So these yes, gym can definitely cause these kind of disc problems and spine injuries.
Dr. Rajnish, I'll come to you. Again, the same question. Do you routinely see these patients in your practice? And once there is an injury, then how do we go about?
So what happens is, this is a very common scenario nowadays, because more and more people are going to gyms, so they're doing gyms continuously. So this is a very, very common problems that you get. The most important part is for any type of, pains that related to back or a cervical region is a very good detailed history that you need to take and your examination, which is very, very essentials just to really find out, where you can localize this pain. Many times what happens, patient will come to your OPD, will come with your all the scans and all, that I've got low back, I've got spondylosis and other things. So you need to really see, what is the importance of this and how we need to treat, because many patient would even come to you that when I'm working I need a bed rest. So you need to explain, what are the current evidence and guidelines behind it. So once suppose if a person has an injury, we know that, prolonged bed rest doesn't help in these type of patients. You can have a rest for about 20 48 hours or something, not beyond those things, because rest doesn't help you out in all these conditions. It is the slowly when you start your active physical activities, which are very, very essential, we need to slowly and slowly reintroduce physical activity, which has to be under supervisions. For initial stage, we can give the patients, NSAIDs or any type of painkillers, even a muscle relaxants does help in these conditions. But they're very small data behind them, and but they have all found them to be useful. So importance here is you don't need a prolonged rest. You can have a rest for about 24 to 48 hours. Beyond that, your activation is very, very important, which are going to help you out, which has to be under supervision, so that at least you not overdo the things and it improves the person.
Sir, what are the usual common presentations that these patients come to you with?
Generally what happens is they would be generally coming with those acute low back pains. Okay, if we see an acute low back pains, when you try to really elicit a history, it's important that you need to really pinpoint where these people would be having the pains. They can be one having a disc pain, that is a discogenic pains. You can have a facet joint pains, which are very common in these days. You can have a pain of an SI joints that we need to see about, or it can be myofascial, which is a very, very important pains, that the pains is in the muscles as well as the fascias, which causes them. Because many of the patients, if you take a good history, they could be having a fibromyalgia, chronic pain syndromes. So history is very, very important, and with the history and examination, you try to pinpoint each and every way by which you can really define these things, because these are some of the most common cause. If you see a low back pain, 80 to 90% would be these. There will be 10% would which be with the red flags, like there can be spinal fractures, or one could have a malignancies, or one could have other neurological conditions like cauda equina syndromes and all, because those will be really differentiated with our examination. So it's very important that we take a good history and examination, and then we proceed in these patients.
Dr. Neeraj sir, do these patients always present while they are exercising in the gym, or can the presentations occur next day, or let's say in the morning after?
So they can occur immediate also, or they can occur after also, after within 24 hours also, if the patient is doing such activities. So first thing, as totally fully agree with Dr. Rajnish, whatever he has said. And I would like to add that once we do the clinical examination and we are sure that, okay, he has got nothing much serious, and it's only a lumbosacral sprain or something like a muscle pull, or it's a myofascial pain, then the first thing we need to educate the patient. First thing is we have to tell the patient, because what happens, the patient will come with a MRI and with an MRI report, and MRI report will be showing like in this case you can see there is degenerated disc at L4-5 with disc prolapse with L5S1, degenerated disc with L5S1, and patients are scared. Patient will say कि sir हमारा surgery होगा क्या, हमें surgery करना पड़ेगा इसमें. Patient will come with all those questions, and why this has occurred, why this has occurred. So patient will have, everybody is doing gym is for good health, then why is this happening? So so we need to educate the patient that doing exercise is not wrong. Basically, doing exercises are not wrong, but since your muscles are weak, core strengthening is not there. So whenever you lift the very heavy weight, the whole load comes on your disc and your bones there, and muscles are not contributing to this lifting of the weight. So because of this, whenever you lift the heavy weight and you are bending forwards, there is rupture of the outer part of the disc and disc bulge come out. And because of this, there is pain. So if you do the proper exercises, if you are doing warming up properly, if you are doing core strengthening of exercises properly, then you can always lift the weights. In other, if you are doing properly, you are doing sports activities like the trained professionals that who are in Olympics or in or those who are going for any state national level game, they are all lifting heavy weights, but they are not developing these problems. These problems are being developed by the local gym, the people going to the local gym, because though there the proper guidelines are not followed. So we have to teach
Basically,
them
over enthusiastic.
over enthusiastic. So we
Okay.
have to tell them that doing gym is not wrong, but you have to do it very properly, and you have to proper follow certain guidelines.
Okay. Dr. Rajnish sir, what are the other sports that you see this other than the gym? What are the other sports that you find that these injuries are common, or you find patients from these injuries?
So there can be number, sports injuries are very, very common now, but with a good trainings, people generally avoid them. So, things, like weightlifting, because again, your core muscle strength has to be very good. So if you do not have a very good training, weightlifters can have this problem, gymnasts can have this problem. The
Okay.
contact sports, like football and other games, even like cricket, when you are playing, they can also cause these type of problems. You can have problems in tennis, golf. So if you see, many of the sports would have, till that time you're not having a very good core muscle strength training, and that should be maintained. So that's why very importantly, as Dr. Neeraj said, training, many people go to gym, they'll just try to lift the weights and all without proper training, proper warm-ups. So any type of sports where you train yourself, your core strength of your muscles are not well trained, you're always going to have problems in these conditions.
I would like to add, like I've seen, like in my practice, I've seen patients who are doing playing like badminton or tennis. They have to again and again they have to bend forwards and lift the ball or shuttle. And if their core muscles are weak, so these patients develop the back problems. After some time, they are saying that they're having some disc bulges, disc problems are there in patients playing badminton and tennis, because they have to again and again they have to bend forwards.
Well, that encompasses almost all the sports. So, are there any sports that are really
No, no. No, it's not that we are compassing all the sports. We are by saying this, we are saying that your core strengthening is very important.
Yes,
Core
yes,
strengthening
that's
of
what you.
muscles is very important, and after
Okay.
that, you can do all the sports. You can do
Right.
everything. We are not saying we should do everything. You can go to gym. You can. So the bottom line is this: you can do everything. We are not saying that you should not do sports or you should not go to gym. You can do everything, but but the bottom line is your core strengthening should be there.
Oh, right. So I think we have covered this particular case scenario wherein a young male has come. So let's go on to our second scenario where it is a 45-year-old male. He has just basic office work, computer job, sedentary. So the patient then develops neck pain and back pain after sitting for a very long period of time. Again, there is no leg pain in this patient, and neurology is basically normal. So, how do you basically proceed with this? We'll go with Dr. Rajnish first, sir.
So this is a very common scenario. Most of the people would be coming to the OPD and saying, I've got a cervical problem. So I generally tell them, you first tell me the history, let me examine you, and then we see whether what are the problems that you're having. So one of the most common misnomer is that you have got a slip disc. So slip disc, if you say there are two connotations and there are two things added to it, it shows that you can easily slip out your disc and it can pop back in. So people have those notions कि बाहर निकला तो अंदर भी घुस सकता है सर ये. So we need to really explain everything, what is happening. It's not going to come out so fast, neither it's going to go inside. So you need to make them understand that this thing has happened. You need to really strengthen up yourselves, and all of them would not necessitate any type of surgeries and all. So surgery is something which we don't need to do, and neither it will need a lot of prolonged rest in these conditions. You need to really slowly activate your muscles. You can have a rest for about first 24 to 48 hours. You can have what are known as cryotherapies, heat therapies. People have seen that both. There are studies on heat therapies, there are studies on cold therapies, there are study versus NSAIDs versus acetaminophen, which they have shown that they are all equally effective. So you need to go one way of trying to suppress the pain. If the patient has a lot of muscle spasm, we treat those muscle spasms, and we need to explain to the patient that you need to stop, exercise yourself slowly, and slowly you're going to come out of these conditions in there.
Okay, sir, a question has come from Dr. Subhash Seth. What is this score? What is this score that we talk about? What is the improvement of core strength? We'll go with Dr. Neeraj.
Sir, we have amongst us Dr. Gaurav Sachdev with us. He was the head of the rehab department of Indian Spinal Injury Center. He will be best to answer this.
Yeah,
Dr.
so
Gaurav,
So
please come.
we have a surprise panelist. He is also the co-coordinator of the webinar series. So Dr. Gaurav.
So, yes, I mean, the core muscles are basically the muscles which you are on your back and front. So we need to actually strengthen them because the whole of the spine is stabilized with our core muscles. Like our panelists, Dr. Neeraj and Dr. Rajnish were talking about, any trauma, whether it is even a trivial trauma like a computer job, can actually hit your back or your neck. As far as back muscles are concerned, you need to strengthen your core muscles. You need to do your lifting appropriately. It is more important. Like one panelist said that Olympics also, or the players also, they lift very heavy weight, but then they strengthen their core muscles and then they lift their the weight appropriately. So that is important. Uh, core muscles are basically your back muscles and your front muscles, which we need to stabilize appropriately before we do uh,
Heavy
any
lifting.
lifting or any work on this sort.
Right. So we will now go back to our second case.
There's
That
one thing I would like to add. There is one study also that has come from Queensland, and they have found that, when you're trying to see the activation of the transverse abdominis, rectus abdominis muscles, their firing ratio is very, very important. And so that's why, more obese people would have more of those problems. So because all your core muscles have to be strengthened out, and people have seen them doing it, when the firing of these muscles are better, you have a much better way of improving these type of pains.
okay. Right, sir. So with the patient that we had earlier, who is a sedentary office worker, how do we now proceed to diagnose the patient and to go ahead with the treatment part? Dr. Neeraj, sir.
Yes, so we have to first thing again we have to like we see these patients routinely. These are usually patients who are in corporate office world, going daily, sitting in front of 13 to 14 hours, sitting in front of computer. They'll come with axial neck pain, with or without radicular pain. They won't have any pain coming to the legs, but mostly they are having neck pain and lower back pain. So we have to educate them. We need to explain them that you are using continuously your neck muscles. In the common layman language, we have to explain them. So you are using continuously your neck muscles in front of your computer. So these muscles need to be strengthened. If you are not strengthening these muscles, definitely these muscles are going to pain you. Same is the case of the lower back muscle. And once the muscles start weakening, when the muscles are weak, then you have to understand how our spine is a bone is covered by muscles, your isometric muscles. So if your muscles are weak, then all the load comes on the bones and the disc. Then the second stage will come. Your disc will start degenerating. The disc will start rupture, disc collapse, which they call as disc slip. So all these things will start coming. So first thing is you have to strengthen your muscles, your core muscles. Then this pain won't come. Second thing, which we have seen in this corporate world, because they'll go from the from office directly to the from the home to directly to the office. So there is no sunlight exposure is there in our lifestyle. Even for that goes for us also, doctors also. We all don't have any sunlight exposure, so the vitamin D levels are come. So that is also postulated to be the cause of these all these deficiencies. And these people, all these people are having vitamin B12 deficiencies, vitamin D deficiencies, which is I don't know the whether that is the right explanation or not for can vitamin D, but this has been seen in the corporate world. All these patients are having vitamin D and vitamin B12 levels low, and which theories has said that which can cause again the weakening of the muscles and the bony tissues.
Right, Dr. Rajnish, do do the chairs and the table and the positioning really make a difference?
Yeah, they do make a difference, because if you're too much bending at your neck and all, you are going to really change the dynamics which are present in the spine. So it's very important that your ergonomic chairs, the way you are sitting about, that's very important. So if you have a sitting job also, you walk about in between, stretch yourselves. Everything is very, very important, that how you need to take care on your daily basis, because most of we as a doctors, we are mostly sitting up and doing our job. So if we just walk about a little bit, exercise, stretch ourselves a little bit, they are very, very essential for us, and we should always do those things.
Dr. Neeraj says same question again because I think this is important and people keep on asking like what kind of chair, where should the screen be and all that because we as laypersons our routine setup would be a simple chair, screen in front and a keypad. So any specific things that you would say that
Sir,
are
sir,
required?
sir, 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 we have to explain them because everybody can't afford everything. You may find somebody from some student coming from a poor family also, but we have to tell them this the basic things. Basic thing is that your neck should not be too much flexion should not be there of the neck should not be too much flexion or too much extension. Sometimes we have seen people have put their screens on the wall on the above their head levels and they are looking at their screens like that upward. That can also cause neck pain. So it should be just below your eye level. Your if your eye level is straight, just below it you can see that is the comfortable level, and it should not be your head should not be too much flexed. And similarly, as far as your chair is concerned, your knees should be you should your height of chair should be such that your knees proper knee flexion should be there, and should your knee and hip flexion your hip should not be over flexed. It should not be more than 90-degree flexion of hip should not be there. So all these things should be cared of. Otherwise, nothing, sir, but nothing too much fancy in that.
And anything, let's suppose any particular exercise or any particular thing that we can do while, because if a person who is working, let's say 9 to 5, 9 to 6,
Yes,
sitting
yes,
on
yes.
a chair,
Definitely, we tell
anything
them.
that they can do.
As Dr. Rajnish told, in between they have to make some protocols. Like if they are sitting for 13 hours, 14 hours in front of computer, they should put a paper in front of their on their office on their dashboard that okay after this 45 minutes or after this 2 hours or 90 minutes I have to do certain eye exercises, some neck exercises for 10 seconds, and after 2 hours I have to walk out, just go stretch out and come back. It hardly takes 2 or 3 minutes, but they have to follow this protocol.
Okay.
Just adding on it, I think Gaurav would also fetch for that. There are a number of exercises have been described. There are McKenzie's methods that have been described, that you do flexion, extension, flexion on lying down. But I generally tell my patients, and even we should try to practice. If you can even do a Surya Namaskar every day in the morning, that helps out because it flexes your spine in a very beautiful way. And it was one of the methods that we used to be done by our ancestors, and we should do it and adopt it.
Perfect, sir.
And
So,
sorry, Tushar, sorry.
yeah.
Along with this, I mean, regarding that posture care, as far as computer ergonomics is concerned, one of my favorite topics. There are two, three very important points and very simple ways to tell. One way is the top of your head and the top of your desktop or laptop should be at the same level. Or even the same rule is applicable for your TV screens as well. So what Dr. Neeraj was explaining, that your head should not go up or down. If your head is at the level of your screen, the top of your screen and the top of your head is at the same level, that will answer your question. Foot rest is very important. If you have a foot rest, we will have a 10 to 15 degrees of angle between our lower thighs and our sitting surface. That is the ideal position for sitting. Back rest is very important. It should be very high. Hand rest should be there. The distance between your eyes and your screen should be about 20-21 inches. So these are very small few tips which you can offer to people who are working in software industries. Yes.
So I think that explains a lot about a person who is working in that kind of environment. So now let's move on to our next case, which is a 65-year-old female. postmenopausal, diabetic, presenting with low back pain, knee pain, shoulder pain, and very non-specific symptoms. So the pain usually decreases with rest. And sir, Dr. Rajesh, how would you go about it?
So now this is also a very common scenario because you have got a more of a geriatric patients now which are coming to us. So this is a very common scenario that will have a female postmenopausal, diabetic, or other comorbidities, and you have a pain which is low back, knee pain, lower pains. So what we need to do? So we need to. It's important that in these type of patients we do also a DEXA so that at least we know what is the condition of our bones. So if there is osteoporosis and all, we need to look for those osteoporosis, and then we can really refer to spine people and the orthopedician so that we can take care of them, because that is another cause of a pain which is misdiagnosed as a pain of the disc and all, but we need to see whether a person has got osteoporosis or not, and we need to work on those things.
Right, sir. Dr. Neeraj, sir, again, the same patient to you.
Yes, sir.
Like how do you proceed with the patient?
Yes,
Like,
sir. We routinely see these patients, geriatric patients, who come with not only with back pain, they will have back pain, knee pain, shoulder pain. So as soon as this patient comes, yes, if there is no red flag, as we see in this MRI, there is no significant compression. So we should always think of that whether she is having osteoporosis. At this age group, osteoporosis is very common, and osteoporosis is a very neglected part in this subcontinent. People don't think about osteoporosis. So osteoporosis is a very, like, it's an epidemic, and osteoporosis and people, and if you tell patient about osteoporosis, the common reply will come, two reply will come. One reply will come, sir हम तो कैल्शियम की गोली खाते हैं, एंड सेकंड रिप्लाई विल कम, सर माय
actually,
ब्लड माय ब्लड, हमने डॉक्टर ने कैल्शियम कराया था, हमारा ब्लड कैल्शियम तो हमारा ठीक है. So they have to, so we need to understand, not only patients, clinicians also. So we need to understand that blood calcium is, by measuring the blood calcium, you cannot quantify the osteoporosis. The blood calcium is something different. Calcium strength, your bone strengthening is something different. These are totally different things. So we need to undergo the bone density test in these patients, and we need to and not only diabetic, the patients who are, most of these patients are hypothyroid also. Patient taking medicines for thyroid, patients on blood thinners, diabetic patient, all these patients are very much prone for osteoporosis. So definitely we should go for bone density test. And for bone density test also, there are some, like in routine camps and all, will do some, there's some, so heel test, some heel test is, says all those tests are not advisable for bone density. Either you should go for a DEXA scan or a QCT scan is there. So there are different proper tests are there to quantify this bone density. If it's more, if it's between, like if less than -3, then if the T score is less than -3, we identify them as patient with osteoporosis, and and proper treatment needs to be started. For that, we start with the calcium supplementation. Along with calcium supplementation, very important thing which we need to tell them is the high protein diet. Because what is osteoporosis? Osteoporosis is not only basically your bone structure gets weakened. It's not only lack of calcium. So it's not osteomalacia. So these things are to be understood by the clinicians. So that osteomalacia is different, osteoporosis is different. Osteoporosis means हड्डी में छेद हो गए हैं, मतलब बोन का स्ट्रक्चर में छेद हो गए हैं. इट्स नॉट ओनली लैक ऑफ कैल्शियम. सो बोन स्ट्रक्चर नीड्स टू बी स्ट्रेंथन्ड, और जब बोन का स्ट्रक्चर होगा तो उसके ऊपर कैल्शियम डिपॉजिट होगा. सो बोन का स्ट्रक्चर जब, बिकॉज ऑफ लैक ऑफ हॉर्मोन्स, बिकॉज ऑफ पेशेंट इज अ पोस्ट मेनोपॉजल पेशेंट, because of lack of hormone, bone structure is being degraded, and so that structure needs, and that structure is being, can be built up with high protein diet. And along with high protein diet, we have to give the calcium supplementation. And along with that we have to also see that bones, to increase the, like, osteogenic activity, there are different, teriparatide injections are there. And to decrease the osteolytic activity, we have bisphosphonate. The bisphosphonate tablets are there. We give osteophos tablet weekly once, tablets are there. There are monthly once tablet is there. Then now injection has come, that denosumab injection has come, which can be given 6 monthly or we can give like daily or for osteo to increase the bony activity, to increase the bony structure, that is also increase the osteogenic potential of the bone. We are teriparatide injections are given, which are given daily. Previously we used to give for 2 years. Now the recommendation is for 2 + 2 years. We can give for 4 years. So there are different modalities which we can treat, but first thing is we have to diagnose it. So first we have to diagnose it that okay, this
Exactly.
is a patient of osteoporosis. So
Right.
treatment part is something different. First thing is we need to diagnose it. Sometimes this patient will come with mild disc bulge and they will be feared of with some surgery, and they will be advised surgery somewhere. So all these patients don't need surgery. These patients needs assurance that we tell them it's osteoporosis. This pain will slowly they will subside, and we have to treat osteoporosis in these patients.
Sir, there a lot of times the elderly patients also come in with very non-specific symptoms which do not really fit into any of the categories that you have said.
Yes,
So
sir.
how do you then find it out that whether it's because of these pains or it is age
So
related?
usually, sir, these diabetes, we have to tell them that diabetes can cause non-specific pains. Osteoporosis can cause non-specific pains. So whenever I see a patient with HbA1c more than 8 or 9 with these problems, I tell them that your main problem is diabetes. So because diabetes can cause problem everywhere, it can cause shoulder pain because diabetes can cause inflammation of all the membranes,
All the
all
membranes.
the tissues.
Exactly.
It
Right.
can cause your shoulder pain, it can cause your back pain, it can cause your knee pain, everything. Yeah, if your HbA1c is high, so you have to control the diabetes. And similarly with osteoporosis, if osteoporosis not only bones are weak, once the bones weak, bony structure gets weakened, muscles also start aching. So these two conditions, osteoporosis and diabetes, can cause non-specific pains.
Right. And Dr. Rajnish, anything that you would like to add to this?
So just like to add one thing, even because in this age group you are also having a hypothyroid, so that's another important thing for your broom, as Dr. Neeraj said. So we these all can be a reason behind it. So we need to see if there are specific neurological complications. We need to rule them out. Then there can be non-neurological that we need to manage accordingly, and we need to tell the patients, and we need to always tell the patient what we are going to achieve. It may not be a complete pain-free that the patient might have, but with physiotherapy and with some of the medication we will try to really take care of the pain as much as possible. So we need to have a very realistic goal when we are treating all these patients, and not just put those tell the patients that your pain can go off and we'll treat in that way. So you need to really explain what we are expecting out from the treatment also.
Right. Right.
True.
In
So
this in
I
this context, Dr. Tushar, there were two
yeah.
questions. One was role of steroids. Uh, in the initial stage, they were asked role of steroids for back pain. Which is the steroid of choice and why? And the second question which was asked was, are there any role of certain modalities like TENS, IFT for early recovery?
Okay. Dr. Nitin Kaura, if I'm right. Right. Yeah.
Should I
Dr.
take the
Rajnish?
question?
Yeah.
Okay,
Yes.
Dr. Rajnish, okay.
So,
Dr. Rajnish,
so yeah, for I will tell you, for if we come to the pain aspect, or there can be two things. You have got one is a pharmacological and the other is a non-pharmacological way you treat the pain. So pharmacological, the evidences that have been all been seen, and there are also the neurology WFNMS guidelines also on them. So you have got acetaminophen, you have NSAIDs. There are studies which have shown that opioids and the opioids analogs are good, but they're only taken for if you have a pain which is continuing and not being treated with NSAIDs. On steroid, they have worked out, but steroid for a long durations in a low back pain is generally not recommended. But if the we are talking about an acute low back pain here, that is which is within the first 4 weeks. So it's generally not recommended. It's only these three things are recommended. Even people have seen if the patient doesn't have any neurogenic pains, then giving gabapentins, pregabalins in the initial phase also doesn't have any value in that. And when we come to the non-pharmacological things, people have seen that exercise is one we talked about. The therapies like a thermotherapies and a cryo, means both heat and cold, has got a value in that. Tense, yes, it has got a value in that, because that also helps in these patients. And then people have seen that acupuncture and other maneuvers can also have. They are not very good evidence, they are lesser in the evidence, but tense, yes, it has got value in that.
Dr. Neeraj, what is your take on gabapentin pregabalin?
yes, sir. So yeah, sir, we need to. Somebody has asked about epidural steroids also.
Yeah.
So we need to understand that if there is an acute low back pain, which may be because of this gym injury, or just because of acute disc bulge. It's only a back pain. So it's mainly because of the myofascial structures, because of the just because there is a muscle spasms, and all these patients don't need gabapentin. Gabapentin is basically whenever there is a radicular pain, or whenever there is a pain relating to the legs, then only we should use gabapentin or pregabalin. For low back pain, gabapentin and this pregabalins are not required. And secondly, someone had asked question about epidural steroids. Again, that goes for epidural steroids is all again it is for radicular pain. It is not for back pain. Back pain can be subsided with just for 24 to 48 hours of rest, and with some anti-inflammatory agents. And along with this non-pharmacological, you can apply TENS or hot packs or cold packs. All this can be done to relieve for back pain. That
In
doesn't
fact,
need gabapentin or pregabalin.
because
Yes.
gabapentin and pregabalin usage has increased dramatically over
Yes, yes.
OTC.
Yes.
It has almost become an OTC drug now.
Yes,
Yeah.
but
So,
that is for leg pain. It's with the leg pain, not for back pain. At
okay,
least we don't practice it for this thing.
perfect, sir. So now we'll move on to our next case. We have around 25 minutes still remaining with us. So then afterwards we can have a overview again. So then the next case is yeah, 55-year-old male, diabetic, with an HbA1c of 10.8, hypothyroid. He has back pain with pain in both legs, numbness and burning sensation. The symptoms are present throughout the day, and they do not decrease with lying down or resting. And the patient is not able to sleep due to burning sensation in legs. So, Dr. Neeraj, we'll start with you. How do we go about this particular case?
So whenever I see such a scenario in which the patient says that I am having burning sensation in both the legs and pain is not subsiding with rest, and HbA1c is 10.8, my first thing, and the MRI doesn't show any significant compression. And even if MRI showed significant compression, my first thing is refer to neurologist for his expert opinion. Dr. Rajnish.
Dr. Rajnish, sir,
Because
your
I am
question
feeling
now.
that I know that this patient won't, even now this patient is not having any significant stenosis. Now, even if
Yes.
significant stenosis is there, I won't operate this patient. I know this
Yes.
patient won't recover with surgery.
Yes.
So this patient has to be referred to Dr. Rajnish.
So this is a very common scenario, diabetics, HbA1c too high, you have burning sensation, pains which are present in the lower limbs. First and foremost thing, you would always need to work for your diabetic neuropathy, because these are very common and they can have very varied presentation, which is very, very important thing. Secondly, which I need to few things that we need to discuss about is, sometimes in a diabetic, we know the most common is a diabetic neuropathy, which is peripheral neuropathies, cotton wool sensations that we know. But we also have something which is known as amyotrophies, in which you have very severe pain, which would be in the thighs, and which are pains, there is no sensory loss, and there are motor weakness, and you see a disc. So you think about it is something surgical, but it may not be surgical, because these are diabetic amyotrophies, which are more like a radiculopathies. So there is polyradiculopathies because of diabetes. So in a diabetics, we need to first see, analyze these patients, try to really treat them in a proper way, control the diabetes, and not just jump out because there are small lesions in the spine to go for any type of spinal surgeries. We need to first see, and if it doesn't improve or the symptoms are progressing, then only we try to see, because first and foremost is the diabetic neuropathy, which has to be corrected, because they can have a very varied presentation in the lower limbs. So we need to be very, very sure how we need to treat them. Plus, if you see these type of patients, because of a neuropathy, they can also have a restless leg. So one has to be very much sure, sometimes if the patient has got more pain when he's lying down in the bed, and he improves with a massage and all, so even just giving a neuropathic treatment doesn't help. We also try to treat those restless leg syndromes symptoms also, which can be very, very, gratifying when you treat these patients, because in them the patients can be relieved like anything, and they can have a good sleep. So you need to see what are the things and components that the patient has. It's just a neuropathy or something added along with a neuropathy, and we need to treat all of them together.
Right, sir. So, how many of these symptoms they usually revert back after the diabetes has been controlled, or how many of them persist? I would take it that
Okay.
way.
So there are two, three things. Many time if you have a burning sensation in a lower limb, and then you even retrogradely try to investigate, like you do an NCV, and then you try to get all the blood parameters from many, and you find that the patient have a diabetes. So it can be one of the presentation of a diabetes, or it can be one of the complication of a diabetes also. So when you come to the treatment, you do not have a very definitive and a treatment that can be 100% in them. In some, it can easily be treated. In some, it becomes a very big pain to treat this patient, especially if you have a very small fiber neuropathies. They are very, very painful and it's very hard to treat. But if you go for a treatment, good control, walk and exercises, yes, at least you can control them in the sense that the patient might not have a lot of problems. It cannot be 100% cure, but at least 40-50%, at least you can help the patients. In some of the patient can go till about 80%, but when there is a small fiber neuropathy, then it becomes a little bit problem for us.
And Dr. Gaurav, what is the role of physiotherapy and occupational therapy in these?
Uh, Very important. So in the initial stages, we need to reduce the inflammation by painkillers or local rest or heat or cold therapy. Along with that, we need to do some stabilization exercises. Later on, further on, slowly we will start with static strengthening exercises and then strengthening exercises for your core, back muscles. And simultaneously we need to take off all these anti-inflammatory measures which we have taken in the form of painkillers or heat or cold. So, and ultimately the patient has to go on exercises along with, yes, the posture care, which is very important. That depends on your work profile. If your lifestyle is basically on computers, so computer ergonomics is very important. Even otherwise in your posture care, nowadays because of the use of mobile, everybody's neck is basically flexed most of the days. So
That's true. That's true.
so we need to be very careful as far as our posture is concerned. The way we sleep, the mattress, the sofa is the worst ergonomic furniture which human being has made. So one should avoid the use of sofa if you are having back pain. It should always be मैं तो हमेशा कहता हूँ डाइनिंग टेबल का जो स्ट्रेट चेयर है, that is the best place to sit if you want to sit. So the way you see your TV, the way you lie down. So posture care is very important. Posture care and exercises. These are the two ultimately long-term solutions for your back pain and neck pain.
Well, there's a question that I've been hoping I'll ask a orthopedician, a neurologist, and neurosurgeon, and an occupational therapist. How much do the orthopedic mattresses make a difference? The ones that are sold commercially as query, I can say quote orthopedic mattresses. And Dr. Gaurav.
Well, my teacher at Safdarjung, he used to say, जो पुराने जमाने में जो कॉटन का मैट्रेस था 1-1.5 इंच का, that is the best mattress. And at times I used to say to my patients, जो आप सर्दियों में जो आप रजाई यूज करते हो, वो आप as a mattress start कर दो यूज करना. That will be a better mattress.
Dr. Rajnish, sir?
I also believe in that, because these are more like a selling gimmicks that we have. And as Dr. Gaurav said, plain mattress, that's as good as anything that you can use for your spine and your back. And
Right.
important is exercises. We should be more focused on exercises than these type of gimmicks.
Right. So I think that takes care of this particular patient. Let's move on to our next patient, which is the last patient that we'll be discussing. This is 45-year-old male, has low back pain since few years, and now pain has started coming in the legs for a few months, and it is increasing since the last 2 weeks. There is numbness and there is heaviness in legs, and the symptoms increase with activity and decrease with rest. So, Dr. Neeraj, sir.
Can we see the MRI? You can't see the MRI.
Okay, yeah.
Yeah.
Yeah, okay. Now, since we can see the patient is a young male, a middle-aged male, having pain, and he's having a chronic history of back pain. And now since the 2 weeks, patient is pain has started coming in legs, numbness, heaviness is there, claudication is there, and symptoms increase with activity and decrease with rest. And once we see the MRI, we see that yes, he has got a severe discogenic stenosis. So these are the patients we need to be careful. We need to explain to the patient the pathology. Yes, your disc has come out, or there is a obstruction in the spinal canal because there is stenosis. But we have to carefully examine these patients, and we need to check the neurology, whether any motor deficit is there or sensory deficit is there, if at all the deficit is progressing. So in one more thing which I like to highlight in this, we have to see what the progressive neurological deficit, progressive pain and progressive neurological deficit. If it's not progressing, if it's not progressing, if the pain is not progressing, and if the neurology worsening is not there, then we can go for conservative management in any patient, in any spine patient. As I always say, 90% of the patient don't need any surgery. Only less than 10% of the patients needs spine surgery. The
Okay.
patients who are having if the slowly there is a progressive neurological deficit, or progressively there is increase in pain, and both in any of these things is there, then yes, you can. And if the MRI is showing that there is a large disc is there, large compression is there, yes, in these patients, after observe, initially you can for 3 to 4 weeks, 6 weeks, yes, you can try for conservative management with analgesics and physiotherapy and all exercises. And if the pain is progressing, or if there is a neurological worsening, these patients needs decompression, which can be which can be done by minimal invasive techniques like microscopic discectomy, microscopic decompression, or endoscopic decompression that could be done. So
Uh,
initially, but yes, clinical examination is very important in these cases.
Dr. Rajnish sir, before the patient goes to the neurosurgeon, what are the ways that you can make him, let's say, comfortable for the time till they reach the neurosurgeon?
So there are two, three things, as Dr. Neeraj pointed out, it's very, very important, because why the spine surgeries are so basically reluctant and people are not ready to go is because many times you do a spine surgery in those people who don't need them. And that causes a bad name for a spinal surgery. So in a spine case patients, as Dr. Neeraj said, how you're choosing a patient for the surgery is very, very important. It is not just an MRI by which you choose. You see an MRI and you don't say no, this patient can go for surgery. It is how his clinical condition is going, how his neurological condition is. So that's why before seeing an MRI and getting biased with it, we need to have a very good history of the patient to see whether his condition is stable or is it progressing or not. His neurological examination, if you're finding any deficits, if the plantars are problematic, if there is a dorsiflexus which are weak, so you need to examine this patient very thoroughly. And once we find that the patient hasn't deteriorated, is stabilized, you can go for, as you're managing out any of those back pains, we go for painkillers if it's needed. We can go for pregabalins and gabapentin in this patient if they have a radicular pain, and we go for an exercise which is a graded exercises, and you find they improve. But if it doesn't improve and the patient is progressing, then yes, we have to go for a surgery at this period of time, and then we refer out this patient. So it's very important how you choose your patients and try to think what the patient needs at this moment of time, so that at least because many of the patients will come to you and you tell that you have to go for a spine surgery, they think you are trying to really say something which can be avoided. So it's very important how we can choose it, and we need to explain why you need a surgery at this period of time and why you don't need it. That's the way we should go in this. So till that time, you need to just treat it just like a low back pain, giving the pain. Suppose if the patient is having pain, give him the painkillers. If the patient is having more of a muscle spasms, you can give a muscle relaxant. If the patient is having more of a neurogenic pain, give those things and start those exercises and physiotherapies for us.
Dr. Neeraj sir, like once the patient now has come to you, so what all modalities of surgery that you offer, and how good are the previous ones like ozonolysis of the disc, or what were earlier known as non surgical treatments for disc?
See, there are many surgical options. Like if now we are taking that we have patient has finished all the conservative management,
Exactly.
and patient is having severe pain. Patient is neurology is progressively deteriorating, or is having severe pain, not able to walk, severe claudication symptoms. Now we have decided to operate. So there are many surgical options. Before coming to surgical options, we will get his X-rays also. So this is also one more question. Like people will say, why do you? We have got the MRI. Why do you want to get the X-rays? Even MRI technician will say then when they'll go for X-rays. Sometimes I write both X-ray and MRI, and technician will outside technician will say कि MRI हो गया है, X-ray की जरूरत नहीं है, डॉक्टर साहब को बोल देना. So there is a concept of instability which people don't understand. So there is because MRI is being done in the lying down position. Sometimes instability is there on standing X-rays. There is instability of the bones which is not seen on lying down MRI. So we need before coming for surgical option, we should always get the dynamic X-rays done and see whether there is instability of the bones. If there is no instability, then yes, the now main thing is that we have to relieve a patient of this compression on the spinal cord. So many ways are there. We can go either we can go discectomy can be done. We can remove this disc safely either microscopically or endoscopically. That the disc needs to be removed. And as far as safety of the procedure is concerned, I can assure that spine surgery is definitely we have come far ahead from the previous times, and it's very safe. And patient can walk the next day. Next day, patient is walking. Surgical risk factors are less than 5% now, and the myths the patient are having that if we get operated, we will get bedridden for whole life. We will get paraplegia. Touch wood, I have not seen such cases of at surgery at discectomy. By doing discectomy at this level, patient getting paraplegia or patient getting these things are not there. We have to need to educate the patient that such complications can do occur if the surgery is being done at the cervical or dorsal level, but at the lower levels these complications are usually not there, and surgeries are safe. And if at all instability is there, then we need to do the fusion, and then on the role of screws come, we need to put the screws inside and do the remove the disc and put the cage. But otherwise, if there is no instability, we can do only decompression, which is a very small procedure, which can be done either endoscopically or microscopically.
Sir, I think robotic also is coming up in this
Yeah,
phase.
robotic is for fusion. If you want to do instrumentation, the robot is nothing. Robot is just guiding you to put the screws. The robot just guides you to find the track, so where you are putting the screws. Ultimately, surgeon is doing the surgery. Robot is just guiding you to put the screws.
Right, sir. Now we'll take up any other questions that we have from the audience. Uh, any questions? Any more questions? You can please put in the chat because it's already 10:52, so we have just 4 5 minutes left.
So as far as I like to summarize in this thing,
Yeah.
so we need to understand that back pain, it's not, or spinal problems. If we see, it's not a disease. It's just a way of life. Each one of us will have degenerated disc or mild disc bulges. It's not a disease. ये बीमारी नहीं, जैसे I tell my patients, ये बीमारी नहीं है. As we grow old, जैसे हमारे बाल सफेद होते हैं, similarly osteoarthritis knee, arthritis ये बीमारी नहीं है. These are the degenerative things which will happen, like cataract in the eyes, which will happen. Things have to degenerate. So but the only thing is we can slow the process of degeneration. We cannot stop degeneration. So this will degenerate. Disc will bulge out. Some disc bulges will be there. So at somebody, each one of us at some point of life will have back pain. So we all have back pain. So back pains, all these are all the part of our life. And the only thing is we have to see which activities are increasing the degeneration of the disc or increasing or harming us, that we have to stop. And we have to do our regular exercises. And we have to see for the red flags, if any of the red flags are there, if there is severe radicular pain not being relieved by the conservative methods, or any pain which is more than 3 months. One more thing at this platform, I would like to tell that any pain, as they say in the chest, any कोई खांसी अगर 3 हफ्ते से ज्यादा है तो टीबी देखें. Similarly, any pain, back pain more than 3 weeks or 4 weeks, continuous back pain, please get the investigations done. We have got cancer is so rampant, and like previously we used to say about tuberculosis, that tuberculosis yet now also it's very rampant, and now cancer is so rampant. So any pain more than 3 weeks, you should get an MRI. And MRI is not just like an X-ray now. MRI. We do need to get MRI done. Any pain more than 3 weeks, Anybody can have anything. So just get the screening MRI and see any. And best thing is to do daily exercises and your lifestyle modifications.
Dr. Rajnish sir, your final words?
My final takeaway is first, like suppose if any patients comes to you or you are trying to see any patients, first and foremost, don't try to see any of the scans or anything. Take a good history. As we have always been taught throughout our medical sciences, our courses and all, that we need to have a good history and a good physical examination. The moment you do, you are trying to remove all the red flags, and you know what type of pains that the person can have. But if the patient persists to have pain, at least try to again re-diagnose. If we have left out anything, then yeah, we investigate it out, or we find if there are other type of pain. Because many time I've seen patients, who have got pain, because pain is something which has got just not, will have an objective. It has a lot of subjective symptoms behind it. We need to see other causes. Many patients are found to have fibromyalgia with this, have been operated out, still having pains, have to have more of a myofascial pains and all. So we need to really see what type of pain with the person has. Take time, take a good history, do a good examination. You will always come to a conclusions for that.
So one question has been asked that what do you say about open surgeries like laminectomy and discectomies and which are still being done in many of the government hospitals? Yes, sir, it can be done. So I'm not against open discectomies. All the main thing is that as far as you are preserving the anatomy properly, you know what you know that if you are kept your parts intact, your facets are intact, and you're doing open discectomy, it can be done, sir. It's not that. Open discectomy is doing a open discectomy is wrong or open surgery is wrong. No, open surgeries can be done. Open discectomies, open spinal surgeries. Everything, all options are good. Only thing is now we have moved ahead. The minimal invasive options are there, so that less blood loss is there, less soft tissue damage is there. Patient can be mobilized next day, and within 2 weeks he is back to his job. That is the only advantage. Otherwise, yes, open discectomies, open laminectomies, everything can be done. This all and still we get good results with them.
Thank you, sir. Thank you very much. I think we'll end our session with that. I would request Dr. Deepmala, our president, to say a few words, and then I'll go ahead with the thanks.
Yeah, a very good morning to all. Am I audible?
Yes, ma'am. Yes, ma'am.
Yeah.
Yeah.
Okay. Very good morning to all. Thank you for joining. That is on Sunday at 10 a.m. And I can see at a time it was more than 65 or so participants. And I think this was our first webinar series, a very successful webinar series. I must say that I'm really thankful to Dr. Tushar for conducting it so well. आप बहुत अच्छे भी लग रहे हो डॉक्टर तुषार 10 बजे आप इतना स्मार्टली ड्रेसअप हो गया
As a change.
and I'm very grateful to our learner speakers, Dr. Neeraj Gupta sir, Dr. Rajnish sir, Dr. Gaurav. It was a very relevant topic, backache or pain, because I think all of us, even doctors, we are also suffering. Even I'm the patient of backache since 15 years. So आप लोगों ने हमें बहुत अच्छी अच्छी बातें बताई, very relevant things to learn. And I'm really thankful to Dr. I can see Dr. Tyagi sir is also with us. Thank you, Dr. Tyagi, DMA President, for joining us. I can see many DMA joins also, Dr. Ashish Sabarwal, Dr. Grewal sir joining us, and many more. I'm thankful to to IMA Dwarka also for supporting us. ये अभी starting है हमारी और we'll keep on doing this और I wish कि आप इसी तरह से हमें support करते रहें and keep on joining us in a large number. Thank you so much. Thank you, Dr. Tushar.
Yeah, in the end, I would just like to, first of all, thank Dr. Prakash, who conceptualized this webinar series when we discussed it with him, and his support was really very essential. I would like to thank Dr. Deepmala, our president, who at the first go, when I told her that we plan to start this web series, she said, yes, go ahead, and all our support is with you. And I would like to thank our secretary, Dr. Amit Tyagi, and finance secretary, Dr. Mukesh Verma, and whole of the IMA Dwarka team for their unflinching support that has been with me in this endeavor. And finally, I would really like to express a huge amount of respect and love for my speakers, Dr. Neeraj Gupta and Dr. Rajnish, who have made themselves available on a Sunday morning and for all the discussions that we had prior regarding the talk. And thank you all very much for attending on a Sunday. And we'll be back with another webinar very soon. The topic will be told to you, and we'll our main aim with this webinar series is to be accessible to each and every physician, whatever their branch may be, to make it so that everybody finds something in that webinar, and later on also to be available to the general public so they can have a better understanding of the topic. So the topics would be
Dr.
such.
Tushar, I just want to say you may invite topics from our IMA Dwarka members also.
Yeah, I would be honored to have topics from the IMA Dwarka members, and we have a list right now of around 4 5 topics. After which we do require a lot of topics which cater to this particular vision of the webinar series that we have. So thank you all. Thank you very much. Thank you for joining, and hope to see you next time.
Thank you. Thank
And
you,
thank you
Tushar.
for finishing in time.
Thank you.
Thank you. Thank you so
Thank you.
much.
Thank you, everyone. Thank you, I am Edward.